Welcome to Epic Media, your online source for interventional cardiology podcasts. Hope you like it.
The Angeline trial. After the results of the last two large and expensive RCT trials in left main about PCI versus KBG, probably new trials comparing these two strategies won't be expected in the forthcoming years. These two trials have settled a recommendation class 1 with evidence A in the guidelines for both strategies in the lowest group of syntax score, 1 and 2A, level of evidence A, for KBG and PCI respectively in the mid-segment of the score, and finally KBG for patients with the most complex anatomy. However, two issues remain pending in the guidelines. The first is if IVUS will reach recommendation class 1, question which will be answered with the optimal trial, and second, if the routine angiographic follow-up will be able to reduce major cardiac events. Currently, the recommendation of this strategy is 2B, with the weak level of evidence C. Few data can be found in the literature regarding the last topic. A small, not randomized trial in 200 patients showed much better results in patients who underwent angiographic follow-up. Additional data stem from the stratification according to the use of angiographic follow-up of a cohort of patients with percutaneous intervention in LM disease. Higher TLR but lower mortality was observed in the subgroup who underwent the angiographic follow-up. Finally, the REACT trial was designed to study the benefit of the angiographic follow-up in an all-comers series of 3,000 patients. The study was finished after 700 patients included due to slow recruitment with result of lack of benefit, although in the small subgroup of patients with LM disease, there was a strong trend towards better outcome with the angiographic follow-up. Design: RCT with angiographic follow-up at 6 months, group of intervention, and clinical follow-up at 12 months, 24 months, and 36 months in both groups. Primary endpoint: composite of death, cardiac and non-cardiac, myocardial infarction or stroke at 36 months. These are the inclusion criteria. These are the exclusion criteria. With Excel and Noble data, an event rate of 20% in the control group could be expected at 3 years. To reduce this rate by 25%, a figure that could be considered sufficiently relevant to lead to angiographic follow-up if the study is positive, 1,009 patients would be needed in each arm. 2 pre-specified subgroups should be analyzed: LMCA lesions treated with 2 stents and LMCA lesions treated with maximum dilation less than or equal to 3.5 millimeters. However, due to the uncertainty of the results and current economic constraints to conduct medical studies, the study design will be pilot with 400 patients at 20 sites. This study may provide data regarding the appropriateness of conducting a study with adequate power. As we said before, the study is a large RCT due to the uncertainty of the results and the economical constraints to conduct medical studies. However, in case of a positive result and continuation of the trail, these data might be included in the adequately powered study, provided that the methodologies are the same. The study is being conducted by 27 centers all around the country. Recruitment completed. Last angiographic follow-up will be performed in February 2024. Last clinical follow-up will be done in July 2026.
Thank you so much. See you in the next Epic Media podcast.